Working out how to use the ethos within its limitations and using techniques like this means that we get all the regenerative capacity from the material without tweaking or changing the components of what it's made of, because if we started to try and change things to get better handling, we start to affect how well it regenerates and its effect on the bone. So this is just an example as a starting case to show how and when we might use the cross-dome technique. As a general rule of thumb, I'm always using two, because I'm using one dome to support the other dome so that it creates something that's even more stable than just one piece of PDS suture on its own. And these sorts of cases are these sort of typical cases where we've lost a reasonable amount of bone across the front. So this picture on the left, we go in with two small drill holes on one side, two small drill holes on the other, and it's really just a case of bending this little blue PDS suture, which is a slowly resorbing, slightly thicker suture, into one hole and then into the second. So you have to estimate. Usually I use something like a Williams probe to have a look at how many millimeters it is across from one hole to the other. Obviously, when you're drilling your holes, you have to be careful that you're not getting close to a tooth. I've noticed that the little drill heads that we have for the demonstration today are a little bit longer than the one that I'm used to using. The one that I use is probably about a millimeter in length, so I can sort of press on it with a reasonable degree of confidence that I'm not going to go too deep. With yours, if you do end up using these ones in clinic, just be careful that you're using them, but not using them and not pressing on too hard or too deep. So, really all we're trying to do is give us that little bit of extra stability to allow the regenerative capacity of the material to have an effect without there being any movement. When we've got the osteoprogenitor cells trying to sort of upregulate and turn over into bone, any movement starts to tell those cells that they're not supposed to be bone and they're perhaps supposed to be something else. And that's when you might get your material washing out, or you might not have your material turning over into bone if there isn't enough support or isn't enough fixation and stability. So the PDS sutures take about 6 weeks to resorb, so that works well with the beta-tricalcium phosphate. But it gives us enough time for it to support itself. So one of the main areas that this sort of came from was using it in GBR techniques. I think it was a group of Italians that sort of presented this, and we had a sort of team lead within one of our research teams that started using it, and we found a few years ago that we started to get some very good results. So really the two main bits of kit that we use is one, in the UK we use the Stabiloc stainless steel drill, which is this green one, which is 0.76 millimeters, and for us, with our PDS resorbable suture, they just fit and work very well together. But as long as your drill is ever so slightly larger than your suture, you're going to be all right. I'll talk you through a case now and just introduce using one PDS suture first. So you can see here on the right hand side and the left, we've got a sort of moderately resorbed area and a very, very thin maxilla. So you can see going with a 2 millimeter wide guide pin, and we're just about at the limit of what the bone can accept and tolerate there. And then there's a little bit of osteodensification with a versakit. There's a radiograph just showing sort of limited volume of bone that we've got. Now this image is probably quite key. This is the Stabiloc green 0.76 drill that I use just to punch those holes in. Now you have to, when you're working in the front of the mouth, punching those little holes in is quite easy. It's always a little bit trickier when you start moving around the side. But you have to work out where you want to put them to create a nice self-supporting cross or sort of X mattress over the area that you're going to be working in. So I always sort of usually go middle and then a third from the top. So just where I draw these arrows, you can see there's one either side. In fact, there's one just below here as well. So no, just one. So if we have a look now, you'll see you take a little bit of resorbable suture and you go into number one and then into number two. The first time you do this, and this is why we practice it, your little resorbable suture that has a bit of tension in it is likely to ping out. So a couple of important things for when you're working and managing your suture. When you're cutting it as well, make sure that you're holding on to the short end of the suture that you're trying to trim so that it doesn't ping off somewhere. If you're holding the long end, you try and just cut off 5 or 6, 7 millimeters, that 5, 6, 7 millimeters is going to shoot off unless you're careful. So you place that number one into the first bit and then you just bend it around and place the other bit into the second. It's ever so slightly more difficult when you do two, but you can just see here how we go from having an area that our ethos is going to be relatively poorly supported with the risk of it just being able to sort of push out, to all of a sudden, once we've got the suture in place, we've got something that gives a real degree of stability there for a long time. And you can see once it's in, got a nice sort of bone condensation there in that radiograph. And we've just closed there, again with PTFE suture, and then just an example of us using an Aurade wrap, which we don't use that often, but we sort of just use it from time to time. So if we look here, you can see this is us just doing second stage surgery. Perhaps if we look at this image there on the left, then we go back and have a little look at how slim and thin that was here. You can see we've got quite a reasonable improvement from where we started from there to here. And this is the sort of position you could use an additional layering technique. So you could go back in and place a little bit more ethos just on top of the previously layered ethos. That's one way that when we have very deficient margins, we get slightly better contours. But in this case, we didn't do that. We just went and put the healing abutment on, left it for 2 weeks, had our impression, and then put a crown on. And one of the things that we notice here as well is at 18 months, there's sort of even further development of the tissue, and it's just looking even better. And there we go. So we have the preoperative view and the 18-month view. Run through and show you the technique that we, to be honest, usually use, where we use two. Again, you can see here slightly deficient, sort of reasonable concavity. So we're sort of using that concavity to our advantage as well. We're not using this on a sort of completely flat maxillary process. It's there's a concavity that we're working within, and we're using this resorbable suture to give us that bit more support. I probably wouldn't use it on a completely flat surface. I'm using it where I'm using the anatomy of bone to help me with healing as well. So you can see this is going for a sort of double suture technique, and they're both crossing over, and they just touch each other, and they just brace each other a little bit. Now, the first time you do this, you have to remember to make your second little bit of suture about 0.5 mil or 1 millimeter longer than your first, because one has to go over the other, but when they do, they work really well, and it just supports and stabilizes the graft again and keeps it in place. And there we go, another case. That one's been 18 months loaded and still turning over nicely. Okay, this is another case. An example like this: patient comes in and he actually sought and this patient came to us specifically because we use synthetics. He was concerned with other materials that might have been used. and we just, this is probably one of our first cases actually from about 4 years ago. So 4 years ago, we were kind of of the frame of mind that maybe a bone block might be better here, but the patient was pretty convinced he didn't want any bone blocks or any animal products. So here we go, same again, just using the PDS suture, straight over the top, one hole in each side, and used to support that ethos in the graft. And there you see pre-operative start and the view at 1 week when the sutures have been removed. And you can see there's a little arrow down here again. I mentioned it earlier. Sometimes we use just a little bit of secondary intention healing to our advantage to try and make up for the fact that you're increasing the volume and putting a little bit of tension onto the flap. There we go. If we come through and we have a look, again, we're not raising huge flaps, but you can see we've got a bit of buccal bone there. And once the healing abutment's been on there, you can see there's a improvement in volume, and that's still very close to when all the work's been done. So that sort of topography and those bumps just settle down with time. So here we go. And this was a custom zirconia abutment, cemented crown, and we got 12 months. And patient's been back now, the CBCT as well, and we can see that there's bone covering the entirety of that implant there. Okay.